Patients with multidirectional instability may have concurrent labral pathology, but many do not. As we can see in this patient, left shoulder lateral decubitus position, there's significant papulousness to the capsule in this patient with multidirectional instability, but no labral pathology. When we view from anterior superior in this patient, again, we can see the absence of any labral abnormality despite the high degree of recurrent instability this patient suffers from. There are a couple of challenges in this particular patient group surgically. One of those challenges is accurately identifying the margin of the glenoid bone. With an intact labrum and an often undersized labrum, this can be difficult. One option would be to separate the labrum from the bone to help identify that by creating a labral detachment. Another might be, as shown here in this example, carefully using the drill bit guide to find the area between the labrum and the bone, which then allows the surgeon to appropriately drill the anchor into the glenoid bone itself. After that's accomplished, we can see here yet another challenge in multidirectional instability capsulorrhaphy in patients with no labral pathology. As you can see here, this retrieval device is used to do a pinch and tuck technique where the capsule is pinched in a through and through fashion, and then this device redirected to try to incorporate the labrum. Again, the labrum can be undersized and in this case, as mentioned, is not detached, making this incorporation quite difficult. And as we can see here, once the device is retrieved, minimal, if any, of the labrum is actually incorporated. So another technique, a labral sparing capsulorrhaphy technique, is shown here. This is a separate example of a patient with multidirectional instability. After roughening the capsule to stimulate healing, the anchors are placed in a fashion shown earlier in this video, and then the capsule is plicated in pinch and tuck technique using a horizontal mattress suture pattern, and the labrum is just completely avoided. Using this technique, as we can see, effective capsulorrhaphy and volume reduction of the capsule is achieved, and this even allows for a bumper effect to be achieved while avoiding the labrum altogether. We can see a posterior inferior labral placement. We can see a more posterior placement. And again, note the bumper that's achieved with this labral sparing capsulorrhaphy. A 6 o'clock anchor is placed in this same patient, and after suture passage, we can again see significant volume reduction inferiorly and an inferior bumper effect that's achieved as well.